Hi, hello, I'm honored to be here today to give a talk as a keynote address. I'd like to thank a committee member of AIOC for kind invitation. My name is Shizuka from Osaka University, Japan. Let me start with this case. This patient received LASIK in 2009 and referred to us 3 years later. Although we didn't have any chance to access her preoperative information, probably her very early asymmetrical keratoconus signs might not be detected preoperatively by topography or tomography. Of course, this is a post-LASIK ectasia. Very early subclinical keratoconus is usually asymptomatic and can be undetected in routine clinical practice. In some cases, very asymmetric ectasia manifests clinically and topographically in only one eye. Such eye is called as formifrous keratoconus. Actually, this is the fellow eye of very asymmetric ectasia. This is defined as the fellow eye of very asymmetric keratoconus, which does not present with clinical or topographical signs, while one eye manifests with clinical keratoconus. However, there is no consensus on the definition of formifrous keratoconus. However, if both eyes of the patient have no clinical or topographical keratoconus signs and show borderline or abnormal values in corneal tomography or biomechanical assessment or other, how do you call them? Currently, there is no standard definition for such borderline cases. The terms such as bilateral form keratoconus could be proposed. This is a case of 21 years old female without any clinical sign. Her good visual acuity is good, and there is no significant abnormal findings in placido topographic maps in both eyes. But when we look at the shine-proof maps by a rotating shine-proof camera pentacam, there is some borderline and values in BADD in both eyes. Fourier analysis of corneal power by OCT can quantify corneal irregular astigmatism. Using anterior segment OCT, we recently reported that an asymmetric component in the posterior corneal surface is useful to discriminate FFKC from normal eyes. When we look at the Fourier analysis maps, there is no abnormal value in this case for both anterior and posterior corneal surfaces, so this eye should be okay. We do perform biomechanical assessment and also recently introduced tomographic biomechanical assessment as well. Shown here is a display from the Corvis ST by Oculus. So biomechanical index CBI and tomographic biomechanical index TBI are shown in both eyes. When we look, although BADD from both eyes are normal, but both CBI and TBI from both eyes are abnormal. Some subtle or mild corneal abnormalities might be overlooked before cataract surgery. In a recent study, 59% of the patients who are thought to have no pre-existing corneal or ocular surface abnormalities showed abnormal values on corneal curvature or biomechanics based on the refractive screening criteria during routine preoperative tests prior to cataract surgery. Objective multimodal imaging is helpful in borderline cases. Shown here is my current cutoff criteria for normal eyes as the screening. We cannot rely on subjective judgments. I would like to share one interesting case. This is a 14-year-old female. So her visual acuities are very good in both eyes, and also there is no abnormal or borderline values in any topography or tomography or biomechanical assessment in her both eyes. Looks very good. However, her mother is clinical keratoconus. She is the third daughter of the three sisters, and her two elder sisters are already diagnosed with clinical or subclinical keratoconus. Therefore, this third daughter has high susceptibility of ectasia. Actually, she has eye rubbing habit and atopy as well. So, she will never be a candidate for refractive surgery. Recently, ASCRS had published the review article about an algorithm for the preoperative diagnosis and treatment of ocular surface disorders. The important message of this paper is that dry eye may compromise results of corneal, cataract, and refractive surgery. As you know, placebo-based topographer uses the reflection of Mayer ring images projected onto the air tear film interface. So dry eye definitely affect the placebo topographic maps. Dry eye also may affect wavefront measurement as well. As you see here in the left side, deterioration can be observed in the wavefront soft pattern after the tear film breakup. And also in the right side, you can see the sequential wavefront measurement for normal eye and dry eye. You can see the visual deterioration after that with the time in dry eye. So preoperative diagnosis and treatment of dry eye is very important. Lastly, let me share a very simple and important tips. Fluorescence staining is a magic tool. Everybody can do it in every clinic everywhere. There is no need for special devices or invisible tests. We can assess the integrity of the corneal epithelium. And also, it enables us visualize of tear film, tear breakup time, tear meniscus assessment, or Zydel test, and contact lens fittings are the example of visualization of tear film. Let me revisit the simple 3 steps in use of fluorescein. Number 1, apply the minimal amount of fluorescein. Number 2, shake well. Number 3, apply gently. This is a very simple 3 steps in use of fluorescein. In summary, please screen patient carefully to diagnose those who have an elevated risk for ectasia. And please check the ocular surface fully preoperatively to optimize preoperative measurements. It is very helpful to maximize postoperative outcomes and patient satisfaction. Thank you for your attention.
Thank you so much, Dr. Ko, for that comprehensive coverage.